Okay, these ladies who are coming up now are our patient panel, and what is unique is the fact that they are also medical professionals. They're all nurses. And without those cool glasses that I showed you before, I'm having a little trouble with this.
Here, you want those?
Oh, thanks.
Oh, I left one in my purse. I hope I don't need them. Okay.
So, being a medical professional as well as a patient, I'm told, is a double-edged sword, huh? So that'll be interesting to hear what's going on there. Judy Goltz here is an RN, diagnosed in 2001 at the age of 41 with a primary in her terminal ileum. Then,
So now everybody knows how old I am.
she's 25 now.
We're all 25.
Rhonda Ayala is diagnosed in 2010 at the age of
44?
44. I just wanted to make sure I didn't get in
25.
trouble this time again. And she is a PNET who has survived a Whipple procedure. So that's a pretty big procedure. Dana Test on the end over there, diagnosed in 2006 at the age of
31.
Okay, I'm allowed to say that's at the age of 31 with a primary in a rectal primary. So without further ado, I want to introduce Judy Goltz once again, and she's going to moderate the panel.
Need my glasses.
Thank you. That was very good.
Good afternoon, everybody. Can everybody hear me? Oh,
In
yes?
front of you.
Okay. Now? Okay. We decided that we were going to keep this organized but informal, okay, so that everybody feels comfortable and you get to ask a lot of questions, and hopefully we can answer everything, and we can introduce you, for those that are first-time diagnoses, to this wonderful life of NETS. And for those that are seasoned vets, maybe you just walk away with a little bit more information. We do ask that you wait for the microphone so that everybody can hear that question or that concern that you have. As Bob said, my name is Judy Goltz, and I'm 57. I was diagnosed at 41, and I had already been a nurse for over 20 years and had never heard of carcinoid. My symptoms pretty much prior to diagnosis were I gained about 30 pounds over a 5 to 7 year span, and I had some GI bleeding. I had some rectal bleeding a couple of times. I never flushed, or so I was never told, but when I look back at pictures, I was flushing. And I never had diarrhea. My tumor was found, exploratory surgery, the terminal ileum. It was only 1 centimeter. It had mets to the lymph nodes, mesenteric lymph nodes, and I had a small bowel resection. Through serendipity, I wound up at Mount Sinai for no other reason than that's where I was recommended to a surgeon. Nobody had mentioned anything neuroendocrine or cancer. But before I left the hospital, I had already consulted with Dr. Richard Warner. So I walked out of the hospital at least having a handle on what I had. 15 and a half years ago, there wasn't a whole lot of information. And what I was told at the time, and not from Dr. Warner, but from my local doctors, was that I had 7 years to live, and there really wasn't a lot of treatment. They didn't even put you on Sando in those days for what I had, because it wasn't in the liver. So, a lot has changed. I'm here to tell you that although it's never a good time to get diagnosed with NETs, it's better than it was 15 years ago. And that the most important thing is that you can live with this disease. And the fact that you guys are all here shows that you are, interested in learning more about it and being proactive. I am currently on lanreotide, and I personally feel that it's helping quite a bit. I do take sandostatin rescue shots when I'm symptomatic, and I am in the process of waiting for the gallium scan because my numbers are up, and I do feel that there's probably something brewing somewhere, but most likely it's going to be small, and we just have to find it. I have been diagnosed as diffuse neuroendocrine disease, which means I don't have any known mets in any major organ that they can find, but that I have multiple endocrine issues. I have thyroid disease, parathyroid disease, adrenal disease. I suffered from infertility, endometriosis, and they are looking into a pituitary tumor now. So that's pretty much the way my disease has progressed.
Okay. I'm Rhonda Ayala, and I was diagnosed in 2010 at the age of 44. When they found it in my pancreas, I had a Whipple surgery. Has anybody heard of the Whipple? Has anybody had the Whipple in here? Hello. Any others? Whipple? Did I see anybody else? Okay. For those of you that don't know, the Whipple is known as the granddaddy of all surgeries. They go in and they take out the head of your pancreas. This is very brief. Take out the head of your pancreas, your gallbladder, your duodenum. Some people call it duodenum, the duodenum. They reroute your plumbing. They take your common bile duct and bring up part of the intestine to the stomach, and then they reroute it. It's an 8-hour surgery. And it's a heck of a recovery. And one of the things I did, because I'm a nurse and I had the Whipple and I had so many questions, is I founded the Whipple Warriors. And the Whipple Warriors is the largest organization in the world now for patients who've had the Whipple. You can find us on Facebook under Whipple Surgery Survivor Group if you know anybody who's had a Whipple. And we have it in, oh my gosh, only 30 countries in all of the states, the United States and stuff, there's Whipple patients. And that's where social media comes into play, and we will discuss that in a minute. At any rate, so I had my Whipple, recovered from the Whipple. They found that the mitotic activity of the tumor, which is how fast the cells are dividing, was little to none at that point, and that was 2010. So they extrapolated and figured I'd had it for 15 years prior. So when you put 15 years and 7 years together, I've had this for about 22 years. I was misdiagnosed for those 15 years as having panic attacks and depression and anxiety and whatnot, when in fact my sugars were bottoming out at 37, 45, something like that, which is very low. That was my major symptom, was sugar, problems and stuff like that, because it's on my pancreas, of course. And so now here I am 7 years later. They took out the tumor on the pancreas. I was good for 4.5 years, and then I had mets to the liver. So when that happened, I was not a candidate for surgery because it was right where the Whipple, the tumor grew right where the Whipple, all the replumbing is. And so you can't make something this big that it has to be that big for surgery. So I was not a candidate. So I went ahead and went on IV chemotherapy. Hair's growing back. And then after that, I had the CyberKnife to take care of the rest of it. So I was good for about 9 months, and then some more mets came back. So I am now on Xeloda and Temodar, which is also known, you've heard of it as Captem. I've had excellent results. Captem. I have had excellent results with Captem. I've been on it in October 1 year. And after only 2 rounds of it, usually doctors want an MRI or something, 3 rounds. After 3 rounds, after 2 rounds, 4 of the little 6 things in there had disappeared. And so my last scan was week before last, and it showed everything stable, because that's what we're going for now, is stable's good. None is better, but I'm going with stable's okay. And so everything's stable, and knock on wood. They did start me on lanreotide when it went into the liver, and that's my story. What else did we say we were going to talk about with that?
Well, you know what? I guess we'll after
Okay,
she tells hers,
go
and
ahead.
we'll kind of
We'll expound. Okay, go ahead.
okay. We'll expand on all this.
Hi, my name is Dana Test. I was diagnosed with carcinoid at the age of 31, so 10 years ago, a little bit over 10 years ago. I was diagnosed as a rectal primary after a lot of people thinking I was crazy. I kept having pain after exercise and got a bunch of x-rays, sigmoids, on and on, until I finally convinced a doctor to give me a CAT scan. And at that time there was quite a bit in my liver, one on my adrenal gland, and my primary ended up being between my sacral bone and my rectum. So we were told to go to Mayo Clinic in Jacksonville, where we spent about 3.5 weeks until they could come up with the proper diagnosis, which was carcinoid. The doctor there unfortunately told us that we would come home, do some very hard chemo, and it would be over. So hard chemo sounded hard, but the fact that it would be over sounded even better. When we actually got home, my mom, who's kind of been my sidekick, started doing a ton of researching, and we found, who we thought, we found who we thought was the best of the best, which we chose Gene Waltrain's team. I had 4 very, very large surgeries with them, and sorry.
No,
God,
they've
I'm
all been in
sad.
our shoes. That's why we're here. This is like
I said I wasn't going to cry. It didn't work. So we, my last surgery with that team was quite extensive. The surgery prior to that, I ended up having to have a temporary colostomy bag. Thank God it was able to be reversed, and that surgery was quite long, about 17 hours. I woke up on a vent. Anyways, I'm here today and doing good. However, I pretty much have used every tool, as they say in your toolkit. I have done Captem, Afinitor. I've been for Y90 in Switzerland twice, and multiple surgeries, 2 chemoembolizations. And just recently, I kind of was told I was in a rock and a hard place and didn't have much left. So the majority of my problem is in my liver now. And I was told I really didn't have much left, but I'm not giving up. And I chose to kind of take it upon myself to do something that they said wasn't safe. And I went back to Switzerland. Instead of getting the yttrium, I got the lutetium. And they told me at that time that Switzerland felt it was safe, and another doctor backed me to go. So I made the decision to go to Switzerland. And after one treatment with a smaller dose than they would use for the average person, because they were trying to be careful with me, they said that if anything, it would maybe be 6 to 12 months stability. That was really hard for me because I thought, I'm doing all this just for 6 to 12 months. But after 2 rounds, we went back and they said that they had never seen anything like it, that most of the tumors were gone. And the ones that were in my liver that they said weren't going to be okay had decreased by, some of them, over 50%. So that, I know everyone's beliefs are different, but I attribute that completely to God in prayer. So, I don't know. The best thing about this all is that besides treatments or surgery, in the in-between spans of life, I am a completely normal, healthy person, and I'm going to keep going.
And I think,
That's what we
thank
do.
you. You know, I think that's why I think this is nice that that we're able to be up here as nurses as well as patients, because you know, it's a double-edged sword, as Bob said, you know, to when you're a medical person or you have any kind of medical background and you're diagnosed with something. it's both a blessing and a curse. But the other part of this that's most important is listening to yourself and your inner guts, and no pun intended, and and really fighting for yourself. And we're going to go into all of those things today. I think Dana, is just representative of how brave most of us are with this disease, and how if you just, you seek what works for you, and you keep fighting until you get the answers that you want, and she's here. So we would like to just make this as comfortable as possible, and as you can see, we're very real people. So there might be a few emotions here. Okay.
Sorry. No, it just brings it real. I mean,
Yeah.
that's what we all deal
I mean,
with.
yeah.
How many of you have not cried? Oh, I don't see any hands. Look at that.
They used to call this, a lot of people have referred to this as a roller coaster, and we all know that. There's highs and there's lows, and there's a lot of coasting times, and so, pretty much strap yourself in, and, you're on for the ride. You're in for the ride. So what I would, what I would like to, just talk about a little bit, and just kind of go back and forth. We're going to just kind of see, kind of our medical background. Have we, did you ever treat anybody with neuroendocrine in your practice at all?
I graduated nursing school in 1987, and
I'm 81. Yeah.
we had big hair then. But
Still do.
in 1987, I had never heard of it, ever. And the only time I heard of it first time was when I was diagnosed. We just don't hear of it.
Now, Dana, you have an interesting way of how you became a nurse, right? You became a nurse
It's amazing.
because of this. correct?
Yeah, I became a nurse because of this. I just went back to school. During my care, I had quite a few nurses that became my friends, that became my role models. So I kind of wanted to give back. So I went back 2 years ago and did an accelerated RN program. School was not very easy because as school started, my health went like this. So the first term of school, I was on CAPTEM. The third term of school, I had a chemoembolization. On the next break from school, I had another chemoembolization and unfortunately ended up going septic. My program was quite demanding and very strict, so the moment I basically was released from the step-down unit of the ICU, the next morning my boyfriend drove me to class. I think that nursing school was, people think I was nuts for continuing to go, but I think it was almost a really good thing for my health, because every morning I woke up, it gave me drive, it gave me a passion, something I wanted to be and look forward to. And so I graduated in December, and I now work on actually a labor and delivery floor.
Oh, new life.
So
Beautiful.
I in the very beginning, precepted in the ICU, and I loved it because I saw a lot of people with liver issues and a lot of people in end stages of life, and I thought, at least I know I'm going to give them the very best care as if I would want someone to do to me. When that time ever comes, which I hope it's not for a very long time, but then I kind of role reversed, and now I kind of see the happier side of it, the bringing life into the world. I do plan on, however, at some point just doing a side job, working in a cancer center or a chemo infusion center, something like that. Just, I'd like to kind of touch someone in that way, but I still think I'm touching people every day because I really love being a nurse. So.
Do you feel like, I know that one of the things that I felt almost immediately was, okay, there's a reason this happened to me and there's a reason that I'm a nurse. It's not just about me. I feel like now an obligation to educate everybody I see, particularly medical people.
Well, yeah, that's one of the reasons, at least with the Whipple, that I started the Whipple Warriors, to educate them, and there's a lot of peanuts that well, have the Whipple. But yeah, you feel this need to give back, and I think that's our caregiving that we're inherit with. But
And I think also, I was really amazed at how little, at least 15 years ago, especially now it's a little different, but how little the medical professionals really knew about the disease. And I'm sure you all have heard the gamut of that, to everything to you're cured, to you're dying.
I heard that
know.
you're cured.
Yeah.
After the Whipple, I had an oncologist, and he had talked to a friend of his who was an oncologist who took care of some NET patients. And at the beginning, you just don't know. You just do what you have to do to, do the best you can. And he had told me that at 99% sure I was cured. So I saw him for a few years, and at one point he refused to do an MRI and told me that I was basically taking up his time, because why would, these other patients in here are sick, and, you're cured, so you don't need to come back. And my husband was with me, and we said, well, can I have another MRI, just, a mental health MRI, And he said no, and at that point he told me that, this cancer you have is like less than 1% of people. And I don't know what that comment meant to him, but to me it meant, get the hell out of here and find one of those doctors who knows what this 1% is, so.
And actually, I want to talk about that, because, that's one of the things that I know the three of us are very passionate about, and that's advocacy and being your own advocate and being part of your medical care. There's a lot of things that, sometimes, especially newly diagnosed people don't realize, is that, it's very important that you participate in your medical care. Communication of any signs or symptoms, communication of any concerns, getting a copy of any and all records. We had discussed about keeping actually a...
It was funny because we didn't discuss this before,
Yeah.
but she and I both, oops, sorry, I kicked the table. She and I both keep, I have literally a binder, a folder, and I have the dividers, and I have my blood tests in one, and I have my scans in another, and we keep them chronologically from, long ago up to the very latest one at the top of all of our scans, even my blood work. I go to the oncologist, give me a copy of my CBC.
Yeah.
Just, you need it in your control. You
Right.
need to have your file with you.
I said I even have my tumor slides.
Yeah.
And, and one of the reasons that I did that is because, places close.
But I don't know if they know that this medical information belongs to you. You're
Yeah.
legally, the days of, it's at the doctor's office, he won't give it to me, are over.
Right.
This is your information.
Everything. You're entitled to everything. And it's important that you have it, because also what will happen is you will go to different disciplines, throughout your life. Meaning, you'll see a gynecologist, you'll see a cardiologist or whatever. And the more information that you can provide them, a copy of this and a copy of that. A lot of times we they'll say, well, have your doctor send us the thing. But you know what? Not all of it makes it sometimes. And sometimes there are things that are important to one doctor and not to another doctor. So it's important if you can provide some of this information and you have it. You don't always have to understand it, but if you have it, it's important. And also, what we also just touched on is finding the right doctors for you. Remembering that you're part of the team and the doctors work for you. And that if you're not comfortable, it doesn't mean that everybody has to have the best personality, but if you're not comfortable with the care you're receiving, or there's not a back and forth communication, it's important to remember that there are other physicians out there. And that a lot of times when I talk to people, they'll say, oh, well, I don't want to upset my doctor. That's a concern, because, the doctor should be more concerned about upsetting you. All right? So.
Yeah. I think that, things have changed, just like we had just heard that medicine's changing 30 years ago. Now, in the future it will change. But I see now what's happening, at least as nurses and stuff, I think what we're seeing is that the generation above us who were the, know-all and be-all physicians, and you just do what they say, no matter what, is kind of fleeting. And now I love that if you have a doctor you're comfortable with, you're kind of a team. And if you don't feel comfortable asking your doctor anything or telling him anything, because of this feeling you get or whatever, this is a collaboration. And if you don't feel that, seek out somebody else or get a second opinion, third opinion, whatever.
And, and the other thing is that what she just said is also true, that you really do need a team. It's not just one physician. The fact that, again, that you guys are all here shows that you're seeking more information and you want to know more. So in a way, I feel like we're probably preaching to the choir because you guys are already in that mode. But that's what you need to bring back to your communities. And if you belong to support groups or know other carcinoid neuroendocrine patients, it's important to communicate that to them too, that, that there's a whole network of doctors out there.
And that's where we were talking about the
Yeah.
social media aspect. Social media has just, changed everything. Being part of a social media group, a Facebook group, whatever you're part of, helps so much because let's say I'm in an area that's very, sparse with doctors and stuff, and I don't know who I can go to. You go on there and you say, hey, I'm looking for this type of doctor. Has anybody any recommendations? Man, you will see them pop up,
You do have to temper some of those
Yes.
websites, though. Because,
Yeah, some of them, these
yeah.
people get really radical on you.
Yeah, some of it, and some of it is, and also even some of the information out there, again, as medical people, some of the things, even if you start Googling, neuroendocrine disease and all that, some of it's a little overwhelming, and some of it's outdated. So, you do sort of have
Yeah.
to wade through that. And that's why I think knowing other people, and having at least some people that you can talk to that have the disease as well, helps.
Yeah, and it's good for you guys to kind of, network while you're here. And
Well, I guess that's why we're nets, right? Because we need to network. Did you have anything to say? I didn't want to overtalk you there, no?
No.
Okay. Go ahead.
The one thing I wanted to talk about is my philosophy, and I think it's the medical people, is the whole patient, meaning the mind, body, and spirit. And you have to work on every one of those three aspects during this to kind of stay whole. Our bodies are going through a lot. When you feel good, do what your doctor's telling you, nutrition, all that kind of stuff. And as far as your mind goes, I don't know about you, but I certainly have been in some dark places mentally and all those things. And, there is actually, and I've seen her, an oncological psychologist in my area. And the things that I say to her that I think are outrageous, she's like, I've heard that. I go, you've heard that? I've heard that many times, Things like, am I going to make Christmas? That's a normal thought for us to have. And so when you speak to someone or you go seek counseling, if you feel, you need it or you don't, it really does help. It does help. And as far as the spirit goes, I'm with her on that whole page, but you believe in God. I told some of the Whipple patients, if you believe in chicken bones, whatever, you just need to go and kind of find that quiet place in you to kind of recharge yourself from this.
And I think that you also you also have to take care of yourself. It's not just about getting the medications and seeing the doctors. I think it's whatever, trying to get rest and try to eat right and try to avoid things like smoking and things that could actually hurt you more. But on the flip side, you also want to have a normal life. This is a chronic disease. This is something that we are going to live with the rest of our lives. I think initially when everybody hears the word cancer, everybody thinks, okay, I'm gonna fight it and it's gonna be over and it'll be done and that's it. And
It's hard to wrap your mind around that.
it's hard
it's
to
chronic.
really, right,
It is.
wrap your mind around the fact that this is going to be here forever.
This is a club you did not ask to join, but we're in it.
Right. But that being said, the key word is living with it. And, you know, I will talk about this, but I know that the three of us live very full lives. And, you know, you make time. I always joke about this. You know, I always say, well, you know, you get your hair done, your nails done. So, you know, it's hair, nails, doctor appointments, colonoscopies. You know, like I do. I put it in the calendar. I put it in the calendar the same way, you know, you do hair color every 6 weeks. Well, you know, I'm doing a blood test every 6 weeks, and I'm getting my lanreotide every 20 days. And I just put it all in the calendar. And that's how I've approached it. And do we have dark days? We have dark days. You know, that roller coaster ride. Do you have those moments where a level has come back and now you got to go for a series of tests?
And the
now
scare
you're
starts
concerned.
all over for a
And,
little
you
bit.
know, or your left knee hurts and you start to think, oh, maybe this is
It went there.
a tumor
It's
in my
there.
knee, you know. You start to lose what's normal and what's not normal.
You lose focus of that.
And I always say that to the doctors. You know, they'll say, well, you know, do you always feel that way? I've probably had this my whole life. So I really don't know what's normal or not normal because I don't have that perception. And, you know, but that being said, you know, you can live with this disease. And
It's a choice, I think.
It is.
I think it's a choice.
I
You
think
know,
you just got to get some sort of plan.
you get a plan, and like I've been in CAPTEM, you know, for a year, and I have some days when my feet hurt, and you know, wake up and my dry eyes, da da da. You know, those couple of days I stayed out, and the next day, man, I'm bounced back. I'm at the mall, I'm doing stuff. You know, I'm not going to let this.
I'm going to
alter me.
Australia next week.
Where are you going?
Australia. My daughter's studying.
we did Machu Picchu.
Yeah.
You know,
I'm getting a little concerned about
Australia?
Yeah, I'm a little concerned about
the outback.
the medications, you know, and you know, getting all that through. But you know, but I'll figure
And
it
what
out.
I do when I travel, see, this is how we're talking, because we live, you know, we do. When I travel, I take all my medications. God forbid something happens
Right.
over there. I want to have that all with me. I'd rather have, you know, like this time I brought all my chemo stuff because,
Right.
you know, I didn't know how long
And
it
you
was
know,
gonna stay.
speaking of medications, I know we're jumping all over the place. I'm from Jersey, I can do that. One thing that's really important, or one thing that's very helpful, I find, is for those that have a smartphone, you know, there's an application where you can put all your medical information. And because I know you know, as we get older, it gets hard to remember the long list of things that you have to tell the doctors when you go there.
I make that list too.
Yeah. So,
great.
yeah, so I know at least on the iPhone, it's under health, and you can put your medications, your allergies. I don't know about you, but I have a lot of allergies, and I've developed a lot of medicine allergies since I've been diagnosed. I don't know if that's common for anybody. Anybody else have drug allergies? No? Yeah? Okay, yeah. Does everybody know that we cannot have epinephrine? Okay, is everybody aware of that? Anybody have any questions regarding that? Okay.
Is that true for any patient or only those that are in syndrome?
Well, really, as far as I'm concerned, it's any.
I don't have the syndrome, and I had bursitis, and they gave me the epi, and this is before I was diagnosed, and it was bad. It was bad. So what I say is I'm not allergic to it. You know, when they say allergies,
Yeah.
I put sensitive, extremely sensitive to epi.
Right.
But yeah, when you get any kind of shots and stuff, they have epi free for the dentist.
Yes.
And any type of that kind of thing. Because the dentist, and then they talk, oh, it's just a little bit.
Yeah.
And that's what happened to me recently, and I said, none, no, I can't have it.
Right. Epinephrine is usually in any, like a lidocaine shot. If you go to the dermatologist and they're going to remove something, or they go to do a biopsy, that will also have epinephrine in it. So it's good to communicate that. Better safe than sorry.
Yeah.
And to my knowledge, none of us should have epinephrine.
Can I bring it, I'm sorry? She says it's too expensive now anyway.
It's true.
Yes.
Oh, yes, I'm
That's
sorry.
right.
Please. Okay.
I just wanted to touch base on something really quick when we were talking about living with this daily. I think that a support system is like my number one key to making it through. Even coming to my first conference, geez, oh Pete. I'm usually emotional
You have a
about
tissue
it.
out there.
Coming to my first conference for me was super huge because you get diagnosed and first of all, you don't even know what carcinoid is, and no one else usually does. And then you get here and you see this mass amounts of people that are dealing with, in some of the similar terms, things that you're dealing with. You make great friends. And then for me, I was pretty young. So when I was first diagnosed, I didn't even know if I was going to have a good life. My mom, unfortunately, sought out every other young person in the room at the time, which there was only about 2 or 3. However, I think that's one of the best things about these conferences, is just being able to talk to everyone and just learn their stories and learn what treatments they've had. And it feels a lot nicer to get it from an actual person going through it than the internet or even a doctor's word. So that's a little bit I thought I'd add.
One thing I wanted to caution, when you just said that through the internet and stuff, some of these people on these sites you'll speak of talk about different holistic approaches and different vitamins, etc. And my thoughts to you is, don't start anything without discussing with your doctor first. I was taking massive amounts of turmeric because I thought that was it. Well, then I find out that turmeric, I don't know, one of the doctors can correct me with this, turmeric kind of lessens or has something to do with getting radiation that's not, something you don't want. I never thought of that. I just thought,
You need to be careful with anything over the counter, even holistic.
check with your doctor.
Herbs and things like that, because there are, really medicine is actually based in herbs to begin with. I mean,
Yeah.
So you need to make sure, because there are things that are, counteractive, and it can lessen. So we were, Dana brought up about why she comes to the conferences, and so what do you feel about coming to the conferences?
I'll be honest with you, the first conference I came to scared the hell out of me. It did. I saw survival rates. I saw this stuff. I was like, I haven't had a panic attack since my Whipple, but I think I was going to have one then, It's the truth. It scared me. And then I started talking to you've had it 20 years? Oh my gosh. You've had it, 8 years? You've had it 3 years? Because I was a goner in my head.
Yeah.
And so it gave me hope after I kind of reversed that thought and started seeing, how many, people and the positiveness here and everything, so.
How many are here for the first time? Oh, wow.
Oh, you can relate to me.
So, do you have a question? Can you just wait for the mic? Go ahead.
Yeah,
Here you
right
go.
behind you. Here you go, sir.
Figure I have a big enough mouth everybody can hear.
Oh, yeah, we can. You go.
I'm an RN. I work for Ochsner.
Okay.
I've been a nurse for 13 years. And I just, coming to Ochsner, learned about Carcinoda.
See, yeah.
As a nurse dealing with this, and you being nurses and patients, what advice do you give the nurses who take care of these patients?
That's a really good
Wow.
question.
Don't forget your compassion. As nurses, you get burnt out sometimes.
And go learn about the disease.
Remember that you're there. Like I always, even on my most frustrating days in the hospital, I feel like, oh God, but walk in, you know what I mean?
Walk in
in your
somebody
own
else's
shoes.
shoes.
I think the most important thing, just not even with this disease, but for all diseases with nursing, is that, or any medical personnel, is that, you never judge a person by what they look like, because you have no idea what they're going through. I mean, even right now, it's even sitting here, I don't know who's the patient and who's not.
And that's the thing with this, we
And-
don't look sick.
Right. But it's we all, none of us look sick, and you don't know what people are dealing with. And I think that is one of the hardest things for medical personnel, because, we immediately have compassion when someone is physically and visibly ill. But when someone comes in that looks like us and says, oh, this is hurting me, this is bothering me, you're already you just automatically, you think, well, really? And so, I really, that was a lesson that I learned, and that's what I try to remind everybody, is that you really have to listen And you don't know, you can't just judge by the way a person looks. You know, it's not all physical. Did anybody else have a question? Oh, okay, wait, here's the mic.
here?
Oh, okay. We're using the mic so everybody can hear.
It's a question. It's also an introduction to myself. I was diagnosed a year ago today with cancer, carcinoid cancer. I first want to say that all of you are very brave and beautiful, coming
We
and
all
telling
are.
your stories.
We all are.
Everybody is
But
here.
specifically, you guys are amazing. So I wanted to thank you, and I think we should get up and do a standing ovation because I do, because they.
Oh my gosh. That's you.
You guys have touched my heart. I'm going to probably cry too. Again, my name is Greta Stiefel. I'm from Connecticut.
Hi, Greta.
And I was sitting in front of my gastro, who is a top doctor in Connecticut, to tell me that I had cancer. She missed my tumor. And Judy, like yours, mine was in my ileum. I was rushed to the hospital. I had a bowel obstruction. I almost died. I went septic. I was expelling my bowels out of my stomach. My stomach lining was shedding.
Oh my.
Prior to that, I passed gallstones, and they missed that in CAT scans and ultrasounds. I went through 5 months of hell, all, of course, with my doctor, who is my own cousin, who is being sued now. Anyway, so for 5 months, I went through massive pain and suffering, and all the while I had this cancer. And then when I was sitting in front of my oncologist after the surgery, after they took the tumor out, he just bluntly said to me, "So you have carcinoid cancer. I don't really, have too many patients, maybe two. You're about the second one. And your survival rate is very low, less than 3 years. I am fully metastasized. I have cancer all over me. I have a lesion 4.8 by 3.6 by 1.5 deep in my liver. I have liver implants, not breast implants, but I'm thinking about it.
Why not?
Liver implants, I never heard of what they were, but I was originally diagnosed with a fatty liver, but I had liver implants on me. I have large tumors on my ovaries, and my peritoneum, my rectum, my colon. Pretty much having a cancer party down there. And I get that a lot with, "You look great. You're not
Exactly. Yep,
sick.
look at you. You're beautiful."
Your hair, why do you have hair?"
Right.
I almost wanted to shave my hair and put it on Facebook. I shut my Facebook down because people were saying that I didn't have cancer. I was so
Yeah.
pissed off.
Yeah.
And so when I get that pissed off, I want to do something. And so what I've done was I created a foundation to raise awareness in my state, and I'm working with the gastroendocrinologist to get to the core of why there's this disconnect. And it's a huge disconnect. And the doctors that treat me are some of the best in the country. Dr. Wolin is one of my doctors. Dana Farber, I have the team of Jennifer Chan and Dr. Fuchs and Mal Kulke. And, it's just I've been bebopped around, and it's so confusing, and it's so great to have this conference and to meet all of you and to hear everybody's story, because as unique as we all are as people, so is our...
Absolutely.
And that's what's
Yeah.
so strange about this cancer. I mean, it's just...
Yeah.
It needs
There's-
more awareness.
there's I agree, and I commend you. I wish you well. I'm glad you're here because I think you'll get a lot of useful information and make a lot of contacts, and I commend you for what you do. I think that's amazing.
amazing. Thank you.
There's a lot of different issues that go on, I think, with why is there a disconnect and all those things. I think you have a whole contingency of medical people that either have never heard of it or they learned about it 5 minutes in some medical school, and
It's literally 15 minutes. My
Yeah.
nephew is at University of Miami Medical School.
There you go.
15 minutes they did, and of course, he knew about it because of me.
and they still will consider it a benign cancer. That's like being a little pregnant, you know? And so, you know, I love that word, benign cancer. But, so, you know, that's part of the problem. You're dealing with those people. And then you are, you know, I can also, I'd like to say, I think there's a sexist part of this, in the sense that when you're a woman and you present some of these symptoms, you know, they'll tell you it's hormones. It's the wrong hormones they're talking
Oh, no,
about,
it's
but
panic
they'll tell you.
attacks.
Right, it's panic attack, or it's menopause. I love that one. Menopause. You know, I've been going through menopause for about 40 years now, okay? Because, that, you know, so there's that element. And I think also, I think that there are some physicians, I was just saying, I was sharing today, I went to a new gynecologist because my gynecologist retired, and when I went in there, I gave him my extensive history, and he said, well, you don't have to worry, it never goes to the ovaries or the uterus or whatever. And I said, well, yeah, it does. And he said, oh, no, never. And I said, okay, well, nice seeing you. You know? So, you know, that's, you have those doctors that think they know about the disease, and they're very, you know...
It's more dangerous than anything.
Yeah. So it is, we are. I think the most important thing, and I know you want to expand on this too, is that there's strength in numbers. And I think just like anything in our economy, no matter what it is, the more we band together, the louder our voice gets, the more information and the stronger educated that we get, and we keep communicating. I will talk to anybody about this. I will talk about it on the grocery line. I will talk about it, and, you know, when I was first diagnosed, I made it, like I was saying before, why did this happen to me? I feel that everything happens for a reason. Mm-hmm. And I decided that no matter what happened to me, because in those days I didn't know, I said, the legacy I want to live is that I'm going to do everything I can for myself, to keep myself alive or help myself, but also to help others. Mm-hmm. If this happened to me, it happened to 1,000 more people. And so that, you know, you just have to keep doing that. And hands of time do go slowly, but things do change. I've seen amazing things in 15 years.
There's
And-
amazing things coming out
Right.
that
and
we're going
it
to hear
just-
about.
It happens, you know, there's so much. And you're going to walk away from this conference with a lot of knowledge. And to see all the things that are in place already, what your options are. Some of you will learn about options that you've never heard of, which will give you, you know, tremendous insight. And also what's coming down the pike. They are working on things. And the bigger we get, the louder we get, the more that people will pump into research and development and things like that. Yeah. Wait.
She's been.
Oh, okay, can we?
Yes, I did get a mic.
She's been waiting for a
I
long
did get a mic. Two things.
Yes.
One of the things that, aside from these conferences, that you can get some information, social media is absolutely a good source for getting information, because obviously we do need to be our own advocates, because this disease is so rare.
Right.
And there are just too many doctors out there that don't know anything about this disease, which is kind of puzzling, but it is what it is. And so the other thing that I would say is to seek out local support groups that where you actually go to meetings.
Absolutely.
I know Phoenix is where I'm from, and we have the best, we've got 30-some-odd people that come. We don't have a specialty team close by, but everybody comes and shares, and we learn from our support groups meetings, which are better to have a physical support than a social media support, in my opinion.
Right.
Yeah.
But do seek out any local support groups for sure. And the second thing I want to know is, when you mentioned about the epinephrine and the dental thing, should you still get Sandostatin before going to the dentist if you're going to have a procedure done, or?
Well, again, you need to discuss that with your doctor, like a rescue shot. I personally do, because for me, anything that causes a stress on me, you know, makes me react. So I will do a Sando rescue shot before any kind of procedure.
But do you do that for yourself?
Well,
mean-
The doctor has ordered it so that I can do that.
Right, but
Yeah.
for us who don't have that opportunity or
Yeah.
not nurses or
It's
don't
something
do
to
rescue
discuss.
shots.
Well, again, in that particular case, it's more for the symptoms, and there's a lot of people that don't, quote-unquote, have symptoms. So I think that's, again, that individual thing where you need to discuss with your doctor. I know, for me, any kind of procedure, I swell very quickly, and I will have this whole systemic thing. I don't feel well, even if it's, I just had a little skin biopsy. My whole arm swelled. I didn't feel good. I have a histamine reaction. So for me, it works.
Well, part of the great thing about being here at a conference is if you have a question like that, we have top doctors here that you actually could ask that too, but again, we can't come up here and tell you what to do
Right.
without,
So one last thing, I have asthma, or at least I thought I had asthma. It might be carcinoid, who knows? But I had the EMS come to my house, and I have dog tags that said, "Do not give me epinephrine."
Right.
And he says, "Ma'am, if you're in cardiac arrest, I'm giving you epinephrine."
Well, and
that's
That's
true.
a different case.
That's true.
Yeah, and
Then you want it.
That's a life-saving situation. This lady has a question right here.
Wait, can I say something about her with the support groups? How many of you do not have a support group in your area? And how many of you with your hands up want to start one in your area because it's needed? So think about that and, talk with some of us and, we can help you with that. So.
And just really quickly, while we're talking about awareness, don't be afraid to tell your story. Like, in the beginning, I was just wanted to be normal, so I kind of tried not to tell anyone
good
what was
point.
going on. As time went on, I just started being a social media nut about it. Whenever I had a procedure or treatment, anything, I started putting it out on Facebook or
It's empowering.
on Instagram or sending emails and just not only letting people know what it was and why it's out there, but asking for prayers. And I think that when you tell your story, it's just another way to let it be known and let people know what it is. So.
Okay,
Go ahead.
what I wanted to say was especially for the people who are here for the first time, a lot of the information's going to go over your head, but keep coming back, because year after year, conference after conference, you start absorbing more of it.
Yeah.
And for me, one of the best things was sitting across the breakfast table with somebody who had 20 years when I had one.
Right.
So
Amen.
they become your heroes.
Yeah. Did somebody else have a question? Oh, over here.
And let us know if you want us to talk about any other subjects. We're obviously open books. So.
Hi, I've been a nurse for 35 years, and I've been living with the disease, not dying from it, for 21 years.
What are you doing down there? Get up here.
No way, no way. I just wanted to clarify the dental epinephrine issue and lidocaine issue. There are mixtures of lidocaine and marcaine you can have locally in the dentist office that do not contain the epinephrine.
Yeah, I actually take Carbocaine, and my doctor, my dermatologist, also gave me my own prescription. So I actually have vials at home, so if I have to go somewhere and get like a local anesthesia, I can actually, it's a single dose medication. Because I also I have issues with preservatives in the multi-vial dose of things. I just wanted to go back to the support group. Oh, okay, one second.
Go ahead, sir.
Go ahead.
Can you talk a little bit about economics? I'm old, so I'm covered by Medicare, and I don't pay for anything.
Yeah.
But lots of the things that you described, that
Yes.
you went through, were phenomenally expensive.
Yes.
What, if anything, do you have suggestions for people who don't have either the financial ability to do them
Yes.
or are covered by Medicare?
Yeah, that's actually something the three of us were discussing earlier today because, for a lot of us and people that are here, obviously, this is an expense to come to a conference and gain, and do all these things. And there's so many of us out there that, cannot. I have a very good friend that doesn't even drive and is on a very limited income. So she is really limited to going to the local doctors and things like that. It's a very tough thing. It really is. That's another whole topic regarding our whole healthcare system in this country, which, is really a huge issue.
Huge.
Yeah, huge, yeah. And,
Sorry.
you know, it is a problem. I mean, it's the cold hard facts is it is a problem. I think the best thing, what we were talking about, is being able to utilize, you know, the networking that you can on the internet or the library or whatever access you can get to some kind of vast, more knowledge.
That's what we're talking about, is also the trickle down of this conference, because hopefully if you're attending in like for you, for example, sir, and you go to one of your support groups or somebody online, or this is what I learned at the conference. So you guys are actually, or can be, if you wanted to be ambassadors and you know, kind of trickle down some of the stuff you learned, and hopefully that might help somebody who doesn't have the ability to attend one of these conferences. Was that what you were talking about, or specifically our medical care?
You mean like the treatments? Are you talking about the treatments? Yeah.
Treatments?
Just know that you can, like, we've had to do several appeals to get things put through.
Oh, yes.
They're denied in the beginning, and then we put packets of knowledge and papers and,
You know, it's like-
everything together, and we appeal it again, and you just kind of keep appealing it. I feel like the more you bug them,
Yeah, they actually have
The more
patients,
eventually-
you know, at least this one, Insurance, Blue Cross Blue Shield of Florida at one point, had a nurse advocate for patients. So, you know, you can go in there and speak to them. And as a nurse, part of my job at one point was handling these refusals and whatnot. And basically what they put you in a computer system, either you match or you don't match, and who is that decision maker who said, I can't have this? You know, so then I wrote a very detailed explanation of why these patients need to have what they have. And your doctor is another source where you can go back and have maybe him write a letter on your behalf to send to the insurance companies.
And also, there are lots of studies that you can actually obtain through some of these, our own websites, to bring to your physicians or send to your insurance company to prove that you need this procedure or that that this procedure is for that.
And a lot of the companies also have patient, I don't know how to say it, but where you
Incentives or-
assistance, some of the medications that we have to take and stuff. I know, like Creon, you can get a $25 off of your, deductible, your payment, co-payment and stuff
Actually,
like
some of the medications you can actually, if you
that.
can show,
Lanreotide has one.
right, if you show hardship, or you can, if you call the company directly, there are times that you can
Programs they
get it.
have.
There are programs usually with every major.
Oh, wow.
Okay, whoa, okay, this guy I think was next.
What did we do?
I'm on a liver transplant list. Is there any subgroup that you could direct me to? I don't know what to expect when it sounds awful,
Right,
but I've been told it's the only cure for
right.
my tumors.
Are you aware of an actual liver transplant support group? But that's actually a great idea.
No, but I'm sure it's out there. What I'm going to do is,
Yeah.
oh, you do know there's one?
Is there one?
She's on the list.
Oh, okay. You're definitely going to meet a lot of people here that either are or have had liver
You two
transplant.
need to get together.
And I actually, I would actually refer this even back to NCAN, because and the Carcinoma Cancer Foundation, there might be actually a list.
There's a group out there called Liver Mets or something. What is that?
Yeah.
There's a group out there that's specifically for liver issues. So get with Marianne or even myself later on, and I'll help you with that.
Just out of curiosity.
for just are you doing a multi-organ or just the liver?
Yeah, I
We
think.
can check into it later.
I've met a lot of people who've had liver transplant. Oh, yeah. Okay, can I tell you? A lot.
Yeah. Yeah.
Yeah, I don't think at least in the United States, I don't think it's as rare. Because,
No, I've met a lot.
yeah, right? Yeah.
There is a list of support groups on the American Liver Foundation.
Okay.
Thank you, sir. Thank you. He's got his computer out there. Thank you.
A question.
So I'm not a net patient, I'm here to learn, but my son had a liver transplant 2.5 years ago for glycogen storage disease,
Ah.
which is a very rare inborn error. And there are some excellent support groups out in social media, but also depending on the hospital where you have your transplant,
Right.
there are in-hospital support groups,
There you go.
both pre-transplant to help you understand what might be happening and post as well. So I would really recommend going to the transplant service that's working with you for the list and joining one of those. And he just started grad school. Okay. And he's getting married.
Congratulations.
So, yeah.
Can we take, yeah, can we bring it over here, please? Can we bring the
Right
microphone
here
to?
in the front.
Just a quick comment about the economics that somebody asked about. Sandoz very expensive.
Yeah.
A lot of us have coverage, but sometimes you have an expensive copay. I learned something before the conference started from Judy, which was very important, and it was about if you're going to go on Medicare, what they pay and what they don't, and the switch to the.
Yeah.
You might want
Medicare,
to. You might
yeah.
want to explain that
And-
real
and,
quick.
you know, and to my knowledge, Medicare only pays for 30 milligrams of Sandoz, okay? Which, you know, and what you're going to learn, I'm sure in this conference, is that recommended dosage is usually 60.
Yeah.
Therapeutic dosage, 60 milligrams. Now, again, remember this is an individual disease, and that there are times that the recommended dosage for you is lower than that, but you're going to hear that in the conference, and
we don't have an answer why.
yeah, and you know, and what we were discussing, and I hope you don't mind that we discuss this, is that, you know, again, and I say this first as a patient before I say this as a nurse, you know, there's other medicine options out there, and perhaps if you can get one that Medicare pays for the therapeutic amount, you know, that might be lanreotide, for example, that might be the answer, because you want to always be on the therapeutic dose, if, you know.
Why wouldn't you be? Yeah.
In my opinion. So, yeah. Oh,
Hi, nursing
see,
patient.
there's a lot of us. Yeah.
What happened to us?
There might be a whole study on that.
She's cold.
Sure.
We're freezing too.
Okay.
Yeah, I'm shaking.
I'm freezing.
Okay. Was that your question? Yeah.
She was saying
turn
it's
the
cold.
temperature up.
Okay, okay. Oh, wait, we need a mic over here. Oh, never mind.
If you don't mind, she's been waiting for one more question.
Oh, sure. I'm sorry. You know what?
Oh, that's okay. I'd like to know if there's anybody in this room who has completed PRRT at all.
Right up here?
Oh, okay.
Twice,
So-
right?
So my
I've done
question.
it 4 times.
4 times.
Yeah.
So maybe, you know what, maybe we can let Dana talk about
Yeah.
that a little bit. Would that be helpful?
Yeah, in
Yeah.
a second, but here's my confusion, and the question is this. So when they did my pathology report and I had my Ki-67 stain, they had me well over at 20% intermediate grade, well differentiated. Another hospital looks at my pathology report and they have me poorly differentiated in high grade. So one hospital, very well-known hospital, I'm not going to say which one, but the disparity between these two entities was so,
Was it from 2 different biopsy sites?
no, the same.
Same biopsy.
One hospital used an extrapolation method on quantitative analysis and using qualitative analysis, and I don't know what those metrics were. And I'm a statistician, so I want those metrics, but they wouldn't give them to
Yeah.
me. So my question is, one entity is saying, no, you can't do PRRT because you're high grade and poorly differentiated, but we're going to use this set of metrics to get you into PRRT. I haven't gone into PRRT yet, but because my tumors are moving aggressively and I'm getting more cancer, I was just told that I was going to have surgery to possibly It's called a colonoscopy, where they, go in and...
Colostomy?
Yeah, where the bag thing, yeah. So, I don't want to be a bag lady, people. So when I questioned the doctors, I said, I was just told I was going to go into PRRT. Wouldn't it make sense to do that first, to see if the tumors get shrunk before you cut me open and take my
Can I
colon?
just ask you a question?
Sure.
You're in Connecticut?
Yeah.
Is this all out of Connecticut that
No.
you're dealing with this? Okay.
Boston and New York.
And Boston, New York, okay.
Well, I was a bag lady.
Yeah.
And it's bad,
It
but
is, yeah.
it's not as bad as I ever thought it would be. It's
Okay.
very livable if it does have to happen.
Okay.
I was fortunate enough to get mine reversed, but for the 6 months I had it, I was actually became so comfortable with it and knew how to keep it clean. I was almost afraid to get the surgery to reverse it. As far as PRRT and KI67 goes, or the metrics, I was never taught about it that way. I was always, I was always told that you'd be a good candidate as far as lighting up on the Octria scan. So the brighter you lit up on the Octria scan was kind of the...
And that's because it has the receptors.
Can I just interrupt 1 second? There is a lot of new people here. Does everybody know what PRRT is? Okay,
No.
can you just explain briefly what PRRT is?
Okay. Oh, I forget what it's called. Peptide.
Right.
Okay, yep, yeah.
Yes, peptide receptor radiation therapy.
Radiation therapy.
like that.
It's been used in Europe quite successfully for probably, in some places, over 20 years. The FDA has it in trials here, and some places are, it's passed. They're still waiting for a little bit more information to fully pass it. I chose Switzerland, Basel, Switzerland. So initially I went twice for an agent called Yttrium 90, which, Yttrium, YTTRIUM 90. Yep. So the thing about the PRRT is it feeds on neuroendocrine receptors. So if you light up quite well on the Octria scan, the agent that they use to go to your tumors responds to that. So yttrium is normally used for bigger tumors.
So what do they do when you go there? Can you tell them what they do?
Okay, so you go there, and usually no one speaks English, and you kind of don't even know where you're going. But then you become a little bit more versed in everything. It's very, very, very simple procedure. It was probably the easiest thing and has proven to be the most successful for me. You get to the hospital. They put you in a room, which will now be your isolation room. Usually you're in it anywhere from 48 to 60 hours usually.
And why are you isolated?
You're isolated because you're beaming with radiation.
Glowing.
A lot of radiation. To the point that usually when you come home a week later, you're still setting off everything from TSA, and I didn't believe them actually that would really happen, but it proved me wrong.
So they give you a note to travel, right?
They give you a note to travel. It's as easy as a little shot, and then they bring you up to a room, and hopefully your tumors respond.
Is
And
it a shot or an IV?
it's a shot.
Oh, okay. I didn't know. Okay, maybe
For
different
you, it
places.
was a night.
Okay. Different places.
Yep, different places, different
patient.
things. Yes.
Yes.
I think MIBG works on a different receptor.
Hold the question till she's done, please. Go ahead.
Um,
So they give you the shot.
They give you the shot. You go in the isolation room. The day later, they scan you to see if the agent took to your tumors. They usually can see because everything turns even brighter than it normally was. You go home and you usually scan in about 10 to 12 weeks. And usually,
Now, were there any side effects? Did you have any side effects?
I didn't have any side effects. A
And
little bit tired.
Did your insurance cover this?
Initially, no,
Right.
but we fought it and kept appealing it and put together quite a large packet with help of some friends that had already dealt with it, and we ended up getting it approved, actually, all of the times that I've gone, but we've had to continuously appeal it. So,
So it's another, you know, there are options out there. Okay, somebody had a question?
The first one is not a question, it's just a comment. I'm lucky I didn't have PRT recently because normally it takes me 2 months to cross the border in the US. It's very, very radioactive. And I respond pretty well. They give me 2 months, 6 months to live 2 years ago when my baby was born. And now it's been 2 years. And my tumor, my liver was a plum pudding. There was no space for living liver anymore, and now all my tumor disappear except my two biggest, and I have one at 3 centimeters and one at 2, so it's why we talk about liver transplant now. My comment is some people take short-acting sandostatin and others take long-acting, so what's exactly...
What's the difference?
Yeah, why they would choose to give you short or long-acting? Because
Okay,
now
that's a really good question. The short-acting, that initially, when you're starting on sandostatin, they will give you short-acting to see if you tolerate it. And so, and actually, that is really the best way to start on it, because otherwise it stays in your system for a period up to 28 days. The other reason we use short-acting, we also refer to them as rescue shots, is if you are symptomatic, if you're having flushing, diarrhea, things like that, you can actually self-inject a subcutaneous, it's like a little insulin needle. And, yes, yourself. And it helps, but the life is very short. It's only a couple of hours, and then it's out of your system. The long-acting, the LAR, can last up to 28. I believe it's every 28 days. There are people that take it every 21 days, or and that kind of gives you that whole gamut of that whole month of coverage. It lets you, in many times, live a normal life. You only have to get the shot once a month. But that being said, there are many people who have what they call breakthrough symptoms in the beginning of the month, before the shot reaches a certain level, and at the end of the month as the shot is wearing off. There are many of us that have breakthrough symptoms with things that happen in life: stress, procedures, other illnesses, food overeating, or certain foods, over-exercise. There are things that can cause breakthrough symptoms. And so...
Sorry, that's not my problem.
So then you take a rescue shot. Oh, wait, can we have the mic here? Thank you. Go ahead.
There's two different thoughts. For example, for pregnant women, there's some doctors who go for short-acting.
Yes.
So I don't understand why, if the pregnant woman's going to have to take Sando for her whole pregnancy.
Yeah, that actually is really more for the medical profession to answer, but I can just tell you kind of...
I would think they wouldn't want the baby bathed in it all the time.
I think that's the idea, is that, to kind of really fight the symptoms, as, give you little
I think that's probably
doses of it.
the rationale behind that.
Yeah.
We don't know, but that's what we think, so you might want to ask a doctor.
Yeah, I think obviously having a pregnancy and any illness is a complication. So, yeah, and I think that's something. I'll be honest with you, I chose, when I went on Sando, I chose to give myself subcutaneous. I started on 3 times a day, and then I went to 4 times a day. So I was giving myself a shot every 6 hours. And I chose that route myself. Again, I'm an individual, I made that choice because I didn't want to go on the LAR. I thought, that this would be a better route for me, especially being a nurse. But to be honest with you, it did not give me the coverage. I was up and down, up and down, up and down all day long. I started on lanreotide a couple of months ago, and it's much better for me. But I do use Sando rescue shots with the lanreotide. Yes.
Okay.
And
Where's the mic now?
Okay, wait, okay.
I just wanted to say about the PRRT, to just have a general theoretical idea about what it is. The same properties of the tumors that have receptor sites for the octreotide that make it light up on an octreo scan is what is working in the PRRT. So they call it theranostics because it's a therapy and it's diagnostics in one thing together. So they put the radiation and attach it with a DOTATOC or dotatate to the octreotide so that it goes directly to the tumors and the radiation is going directly to the tumors. And sometimes they, if most of the disease is in the liver, they can give it in a hepatic artery and goes right to the tumors in the liver. I just wanted to add that.
And they also are speaking on it tomorrow.
Yeah,
A
I was
couple
just
of the
gonna say.
doctors at 1 o'clock tomorrow. They can probably give you.
It'll be very clear to you.
Yes, a very clear
And there will be
understanding.
time for questions and answers at all these sessions. So that's, you know, any questions you even have today, you can write down.
We were talking about.
Wait, we need a mic.
You have to mic.
He's coming.
Where you at? Where you
And
at?
then I know that you have a question. I didn't forget you.
Okay, we were talking, when you went to Switzerland, okay, what was the name of the procedure they did there? And was it like the PRRT?
It was PRRT.
Oh, it was it was done differently? I was kind of confused. It was PRRT that was done in Switzerland.
Yeah,
then.
there's two different kinds of PRRT that they have. There's one called yttrium-90. It's just two different agents. It kind of depends on how large your tumors are.
Okay.
And so there's one called yttrium-90, and then there's one called lutetium, lutetium, 177.
These things, these particular procedures will definitely, the doctors will go into great detail. And again, you really will be able to get your questions answered. Because that, you know, the doctors will be able to explain it, I think, a little bit more in detail.
On the lanreotide, what is the typical dose of the lanreotide?
120 micrograms.
20?
120 micrograms.
120.
Once a month.
Once a month. It's given, it's a deep subcutaneous shot.
Thank you.
Okay.
But it's given like at, you know, it's not something you can give yourself.
It's given in your bottom.
You said something about the Stansted, and I read this on Zebra. Some people get it every 2 weeks. I get mine every 2 weeks. I get a shot. In the last 28 days.
Okay. Well, no, that's okay. That's okay. And then I have to answer this lady's question. But yes, again, everybody's an individual and every doctor will determine. Yes, there are patients that get it every 2 weeks. And there are patients that get it, you know, every 28 days. The usual recommendation is generically is every 28 days. But there are lots of variations on that. And you'll find that.
Well, depending on a lot going on, your symptoms, your numbers, et cetera. And that's why we're all considered zebras, because nobody is the same in here. So your doctor would be handling this a little bit different because of your biology and things that are going on with you. So that's why, unfortunately, with this disease, you can't make one blanket statement. You know, it's not like, hey, penicillin will kill this bacteria, end of story. We're not like that, unfortunately. We're all so independent.
This lady in the yellow had a question.
Well, you said that you were
Up and down? Yeah.
up and down in your systems. And then the follow-up to that, it's like you also talked about breakthrough symptoms.
What are they?
Right. It's like if you're just on surveillance, you know, can you have breakthrough symptoms as well?
Yes. Okay. Okay. And then maybe they would like to explain too. But for me, again, being an individual, like I think we all, and again, I'm 15 years, almost 16 years, so I really know my body and my symptoms. But for me, breakthrough symptoms will be flushing. I will get almost like a slight headache. It's a whole body thing. I start to just not feel good. Sometimes it's fatigue and diarrhea. So if I'm having those kind of symptoms, for me, those are breakthrough symptoms. Like I took a rescue shot today. You know, I'm in a new environment. I didn't sleep really well. I had to move my room twice. You know, those are like little things. But you know, I guess just the excitement of this, you know, so I was having some breakthrough today, so I took a shot, and I feel better since I did. And I'm also at the tail end of my lanreotide, so I know that it's, you know, I'm due for my shot. What was the other thing that you asked? Up and down. Well, that's what happens. You know, what I find on the lanreotide is that I'm much more stable on a longer period of time. When I was doing the Sando all during, you know, 4 times a day, you know, I'd take it, and maybe an hour later I'd start to feel good, and then I felt really good, and then it would start to come back. And, you know, so I was doing this all day. Once I started the longer acting medication, I have more stability. That's what I meant by that. Okay, you too, or?
No, I just, I can tell when my shots due,
Yeah.
like
Oh,
a
yeah.
few days before on the monthly thing. And I have some heads nodding, yes, same thing. You can kind of tell, and then you get that shot and you feel better.
Wait, I think this gentleman over here. Go ahead. Oh, lady.
Hello, my name is Shelley. I'm also a registered nurse.
See?
Living with this.
What the heck? We need to
35
do a
years
study.
as a nurse. Diagnosed in 2012, and I've had 2 surgeries, and I'm on Afinitor and Lando, or Sando, LAR right now. My question is, and this may not be something for later, if my O scan was negative, so it was cold, there was no uptake, would the PRRT even be beneficial?
No.
Okay.
You have to have
Didn't
those
think so.
receptors.
Okay. Okay, wait, we gotta wait for.
And that's the scary part about being in medicine. We know too much, that's the double-edged sword.
I don't need it. My voice is.
But it's also, you know, it's good that you can ask those questions, you know, and what other options you have then.
Remember, we have things coming down the pike that are wonderful too.
Go ahead.
You know what? I can't hear you without the mic. I'm sorry. Wait, who has the mic? Right back here?
Wait, he's waiting to go.
Okay. Okay. Go ahead. You are going to be next. Go ahead.
I think you should discuss the pump. In other words, had the octreotide acetate on a continuous basis, 24 hours. And I think it's more reliable than the PRT, than the long-acting.
Okay.
And I've been on it for a while. I also had the PRT in 2011, and I just finished 2 cycles this year.
Okay.
And I had a gallium-68 scan, I think is also needs to be discussed. I think it's been approved by the FDA.
Right.
And I think the gallium-68 scan is far more efficient than the Octa scan.
Right.
And so
Do you
I
want me?
think
You want me to talk about the gallium scan and all that? Okay. Does everybody know what the gallium scan is? Has anybody had the gallium scan?
Wow.
Okay. I actually did as well. The gallium scan is actually called 68 gallium dotatate SSA PET scan, PET CT. And basically what this is the next generation of the Octria scan. Has everybody had an Octria scan? Okay. All right. So there's reasons that you can have a negative Octria scan. One of the things, like this lady discussed, is you may not have uptake, but for other people it might be that if there is a metastasis, it just may not show because it may be too small to show. Traditionally, the Octria scan does not show anything under 1 centimeter. The gallium scan can show tumors 4 millimeters, and that's a big difference in size. It's also a lot less radiation, and it's a lot less time. You know, again, going to that quality of life issue. It's a 1-day test. So it's faster, it's more sensitive, and it has better resolution. You know, again, the doctors are going to go into more medical detail about it, but it is something that is, like I said, our next best diagnostic monitoring test. Unfortunately, it's not everywhere, and one of the biggest holdups from my perspective has been that it's cost effective for facilities to have it. And again, this is where our numbers come in. I've been told many times throughout this that, there's just not enough of us, going to take that test at that facility for them to warrant, because it involves a cyclotron and all this stuff that they have to have in the hospital. But it is being approved. I can tell you it's already at Holy Name in New Jersey. And then the other aspect of that is getting your insurance to pay for it. So I'm in the process of fighting with my insurance to get mine approved. And it will be approved. But again, that's the other part of it. So that's the gallium scan. Did I answer that part of the question?
Mm-hmm.
Yes? Okay. Okay. Huh?
Again, the doctors will go in great depth to all of this. We're kind of getting ahead of ourselves a little on some of this.
Okay, there was a gentleman here first. I'm sorry, but there was a gentleman here. Go ahead.
In regards to the new people, and if they're, diagnosed with carcinoid, and they need to kind of follow up in regards to if they are scheduled to get a shot of sandostatin, make sure that the clinic they're going to
Very
knows how
important.
to.
We actually discussed
That
that
is
at
so
lunch
important.
today. I cannot tell you how important that is. I'm going to be honest with you. One of the reasons I chose not to do the Sandoz shot, this is an open forum, I'm being honest, is because I know that has to be mixed exactly right, the sandostatin shot. And if it is not mixed properly, you're not going to get the full effect from it. In addition, because it's such a viscous, thick liquid, sometimes you can get some calcification of the muscle and the tissue there.
Feels like little knots.
And again, it may not be absorbed, especially, there's actually a blood test you can take to see if it's being absorbed. And there's actually been a study on that. So that's very, very important. And what I told one of our colleagues, one of our friends today, is that I'm sure there's representation here from Novartis, who makes the sandostatin shot, and they do have literature. And actually, they used to have like a placemat that you can actually bring to your doctor's office so that they can show the nurses, or they will, if you tell them what. You can call Novartis, and you can tell them what doctor you go to, and they'll go in and actually train the staff, because that's very, very important. The lanreotide doesn't work like that, so it's not as.
But the lanreotide has to be given, which is a deep sub-Q, which was the new one for us. And it's basically right before the muscle layer, so they want to go, right where the skin, the layers are. So when you get a lanreotide, remind the nurse who's giving it to you that it's in the directions, hopefully they've read this already, that, sometimes when we give a shot, we go like that and give it, like pinch it up. Your skin has to be spread apart, and then the needle goes in to give it properly. And don't stop, yourself from speaking up. I did it, I survived, and I got the shot right. So you tell them, spread the skin.
And again, this is, learning, first of all, you have the resources with the medical companies. They all have 800 numbers for the patients to call, so if you have questions, they'll send you the information. And again, don't be afraid it's not an adversary relationship with your nurses or your doctors at the office. If a patient came in to me as a nurse in a doctor's office, I would say, oh, you know what, even if I knew and I gave it 1,000 times.
Oh, okay, thanks.
Yeah, I would still want to
But
know
I
how
have
to
to say,
do it.
as the patient, I felt a little funny, honestly,
Sure.
correcting him.
Well, especially because you're a nurse.
Yeah, because then I was like,
know-it-all, right.
yeah, because there's a know-it-all, But I stopped him because he was doing this, and I'm like, oh, I think you're supposed to, it's like really awkward, but you're supposed to spread it so you can get that deep sub-Q. And it felt very awkward, honestly, for me to say that. But I said it once, and now it's like routine, and it wasn't that bad.
Yeah. I just want to say, like, I always make jokes, but it would be like, I always say, like, if you were at the hairdresser and they were going to put, like, bleach in your hair or something, and, you'd say something before they did it. You want to make sure that,
I just wanted to follow up on the gallium scan, which I had done at the National Institute of Health in Bethesda, Maryland.
Yes, I did as well, by the way.
They describe it as a clinical trial, where initially it started as giving both an Octria scan and a gallium scan.
Correct.
The program was so successful that now they've dropped the Octria scan portion.
Correct,
They just
yes.
do the gallium scans.
Correct.
It's totally free.
Right.
You have to meet the criteria to be selected.
Correct.
But they pay a mileage allowance, they pay a portion
Right.
of a hotel. If it fits your particular situation,
Right.
it's a wonderful way to get a gallium scan.
That's actually a very good point. The National Institute of Health does have a lot of trials, and so it really does behoove everybody to spend some time and just sort of, browse their trials to see if there's anything that you can qualify, or mention to your physician if they can check for you to see if there's anything. Because I did do the gallium scan. But at that time, my trial was you had to have a negative Octria scan, which I did. So, yeah.
Okay, I have two things. For those who don't have a support group, is there some way of setting up a table that groups that are in existence can register so that those who don't have a group can find out where they are?
We're going to gas that guy
Shoot
right
that
there.
to Bob, right there.
And so that they can have contact in helping to start a group where they are.
Yep, there you go, right there. There's your man.
And my second question is, we're separately, my wife and I are separately insured. Her insurance covers her stuff.
Right.
I'm scared to death that my insurance will balk at every step
Yep.
of the way.
Yep.
And they're about to change companies
Yep.
this next year.
Yep.
So is there, are some of the
Are
insurance
some
companies
insurances better than?
Yes.
No, you know what? No, because in my experience, they keep changing. I'll be very honest with you. We're in our own business, so I have to pay for my own health insurance. And I know there's no such thing as pre-existing condition, but when you're over a certain age and you have medical conditions, I'm sorry, your rates go up. They just do.
Oh, yes.
And so I pay an exorbitant amount of money, and I still have to fight tooth and nail. I'm supposed to have this Cadillac insurance, and I have to fight tooth and nail. And and that's part of the whole frustration, I think, of being a patient, as well as a nurse, because I know what they're doing.
We know why they're doing it.
I know from the other side of it. My husband happens to be a medical provider. He's a chiropractor, so I see what he goes through on the other end. And it is a big frustrating thing. But again, that goes back to our, I think that you just got to keep fighting them, and you just got to keep sending them, bombarding them with information like Dana was talking about. Hopefully things will change. I don't know.
Go ahead.
Hi, I'm a nurse also.
Oh my God. All right, wait a minute. Wait, time out 1
something
second.
we're picking
Time
up.
out 1 second.
Seriously.
How many people are medical people in this audience? Okay. Wow.
Wow. We
And
need to
how
do a
many
study.
are patients, like actual patients? Wow. Okay, that's pretty impressive. And we are just a small representation of this entire conference. This is only day one. Interesting. Go ahead.
I'm also on lanreotide. I switched from sandostatin, and I thought the injection was a little bit uncomfortable. So where I go, they ordered a spray.
Oh, nice.
Ethyl chloride, which
Oh, that's cold.
numbs your skin, so
Right.
you don't even feel the injection,
Right.
which is wonderful.
Right.
I also, I've had this. I'm a lungnoid. I've had it for 12 years and misdiagnosed first.
Of course.
Went through and was told I should, deal with my stress and whatnot. And
Yeah, we're all.
like you're crazy,
Yeah.
Anyway, I was told at the time, and I haven't really thought about it much, but if you're having breakthroughs, at the time they were saying that it does the hormonal effect, that the hormones that are released into your system can have an impact on your heart. So that's why
Absolutely,
they were stressing.
That's a really good point. The serotonin. Yeah,
Right.
that's a really good point.
So anyway, But
Yeah.
that's it.
Yeah.
Thank you, you gals.
That's a good
have done
point,
a
yeah.
great job.
Yeah, thank you.
Okay.
I'm so glad the people that raised their hands that are in the medical profession, because I'm all about big data, and I have met people in the weirdest ways that have carcinoid across the country and across the world. And I ask this question, what do you do for a living, or what did you do for a living? Did you have a lot of stress in your life, personally or professionally? The answer is yes. I've had chronic and prolonged stress for most of my personal and professional life. And I think there is a direct link to that with the breakdown in the neuroendocrine system and then the cells mutating. And it
I
absolutely
agree
is.
with you. I also, and I talk about this all the time, I think that anything hormonal, it just seems to be on the rise. Any kind of disease involving hormones. I mean, just out of curiosity, how many people have thyroid disease in this room? Okay. That's actually less than I thought. I mean, I do. But I feel like you hear more and more of, a lot of hormone diseases.
We're getting into a whole different foods, milks, hormones. The girls are having their earlier and, that kind of thing. So.
But you're right. Stress is, I think, a big factor. And I think in any cancer. Yes, where's our mic? Wait, we need our mic. You know why? Because not everybody can hear the question. Go ahead.
Thank you. Hi, this is just a follow-up question to your question, actually. I'm also into kind of big metadata. And I'm just curious, in this room, how many people have experienced long-term chronic stress or like a high level of it? Like, could they raise their hands? I mean, just chronic long-term stress or anxiety?
Well, there's an interesting thing with that, too, and I remember Dr. Waltering at one of the first conferences, he said something along the lines that carcinoid patients are type A personalities. Generally speaking, obviously, not everybody fits into that category. And that we all, which came first, the chicken or the egg? Do we feel stressed differently because we have neuroendocrine disease? Or did we cause the neuroendocrine disease because we have stress? Most likely it's more of a genetic thing, something in our particular DNA. And so perhaps we feel stressed differently.
I agree. I think that some people, though, have the proclivity towards things both genetically and organically. So I think that, in terms of like long-term studies, that'd be a really interesting one to have. I think there's an intersection there. That's just my own perspective.
Yeah.
And
That would
actually,
be interesting.
I just wanted to say something else about that, and that goes back to strength in numbers and all those things, is I think it's very important in sharing your medical information with each other and with the doctors and stuff, is to bring up all those things like, commonalities that we might have, because that might be some answers, as to cause or treatment or whatever. For example, how many of us had mono? How many of us,
low vitamin D,
right, have this or that. It's because I'm sure there's a lot of commonalities, or perhaps things in our families. Okay. Over here? Yeah. Yep, back there. Okay. All right, this has to be our last question. We have to wrap it up. Okay.
Hi, my name is Olabisi. I'm an intensive care nurse. I overheard you mention something about diet, having some triggers, and I know somebody else talked about like different other conditions that you might have. So I guess my question is in two parts. One, what are the dietary triggers? Say, I'm a nurse working tonight, my patient wants to eat. What are the certain things that do not, fall in the category of okay things? Also, secondly, has there been a study to kind of look into the effect of the food?
Yes.
What does the food we eat have to do with?
Actually, there's going to be a segment during this conference. There'll be a nutritionist, and you might very much want to attend
be
that.
great for you to attend.
Because that's very important. And to answer that question, and I guess you can expand on this, is a lot of times it's the amount of food you eat. Large meals can be a trigger. Spicy foods, catecholamines, caffeine, right?
Yeah, I have an aversion to spicy foods.
And, and sometimes high fat, so.
There's also going to be a cooking demonstration next, and she's a nutritionist for the LSU group, so she'll be able to help you out.
Okay, don't hesitate if you have any questions and you see us around to shoot one at us, or just say hi.
And, again, thank you all for coming and.
Yeah, that's the best panel I think I've ever heard. So just another round of applause, please. That's great. Tania Moore, could you raise your hand, please? Tania Moore? Oh, Tania Moore is over here. We had a request from her nurse, Elaine Huang, and I think there are two other nurses to just mention her and to give her a standing ovation because today's her birthday.
Oh, happy birthday!
So I hope you can see that there is just a tremendous amount of hope, a lot of things that can be done, and this is just the beginning, but I think this was a great session. Really, really good way to start. Now, Dana mentioned that there's a cooking demonstration outside. It's a net-friendly recipe, which I have right here. Okay, but you can get your copy right outside about 5 o'clock between